everyone. Thank you for coming out to today's event. On behalf of NYU Langone Liver Transplant Center and myself, I'd like to thank you all and ALF for inviting me for today's event. For next 10 to 15 minutes, I'm going to go over broadly. Did I say hours? I can stay here for a number of hours, but I'm going to go over broadly the liver disease, starting from like hepatitis to cirrhosis, and touch up on all of organ allocation, and also give you some tips on what to do after liver transplantation. Okay. So. What is the liver? So liver is the largest organ in the body. It is so vital for life that it is protected by the rib cage. It is weighing between 1.5 to 2 kilograms per person. Has many variety of function which is vital for the sustaining life, such as the detoxification of the drugs, toxin coming from your inner body or outside the body. And also vital for making protein, lipid needed for your bodily function, production of digestive enzymes, production of hormones, and the sugar metabolism. So a patient with advanced liver disease often develop diabetes or they have difficulty controlling sugar. And then also storing nutrients, meaning in your fasting state, the body is in need of extra nutrition. The liver release the nutrient to sustain the energy metabolism. And also have to fight infections. So people with advanced liver disease, they're susceptible to so and so for immunocompromised, susceptible to getting infection. So liver is vital for survival. And currently there's no way to compensate for the absence of a liver in patients with the end-stage liver disease, except liver transplantation. So what is hepatitis? It's Greek terminology for liver inflammation. So it affects approximately about 30 million male, female children of all background, age, ethnicity, socioeconomic status in the United States. There are a variety of liver hepatitis. The reason for hepatitis ranging from drug-induced common viral hepatitis such as viral hepatitis B and viral hepatitis C, alcoholic hepatitis, non-alcoholic hepatitis due to obesity, hypertension, and diabetes. Some other rare form of the hepatitis, including the autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, and also the hemochromatosis. Speaking of two common hepatitis in this country, hepatitis B and C, approximately 5.4 million United States Americans are affected by these diseases. And also 25% of Americans are affected by the disease called fatty liver disease. So meaning 1 out of 4 Americans walking on the street has fatty liver disease. Meaning 5% of the liver, more than 5% or greater of the liver is replaced by fat. And it can lead into potentially liver inflammation, scarring, and cirrhosis. Cirrhosis and liver cancers are as a result of chronic hepatitis. I have to mention that this is a quite important fact. So meaning it is a prevention, early diagnosis and prevention of chronic hepatitis is key to prevent people developing from the cirrhosis and its related complications such as liver cancer. Liver cancer has become the fastest growing cancer incidence in the United States over the past 3 decades. Probably due to the fact that we are seeing more and more patients with patients with the cirrhosis are coming up. These are patients with the cirrhosis due to hepatitis C, cirrhosis with due to NASH. So again, many liver diseases are preventable if you can diagnose earlier and treat it earlier before you can go on to cirrhosis. So next question is, what is cirrhosis? Cirrhosis is an irreversible serious condition in which normal liver tissue is replaced by scar tissue. So liver go through this vicious cycles of liver inflammation, and body's response is to try to repair the inflammation. And during that process, they lay down the scar tissue. The scarring of the entire liver is called cirrhosis. And as the liver lay down more scar tissue, eventually liver going to manifest the liver failure sign, which I'm going to go over in the next pictures. So this top is normal liver, which is brownish soft. Bottom is someone with a liver with the cirrhosis, which is nodular, hard, and shrunken. Again, this patient with chronic hepatitis, about 1/4 of them eventually going to develop liver cirrhosis if you don't treat or do something about chronic hepatitis. Once you have liver cirrhosis, approximately 3 to 5% of those with cirrhosis going to develop liver cancer each year. So let's go over some common complications due liver failure or liver cirrhosis. First, jaundice. So often you may see patients with yellowing of the eyes or skin. Aside is basically retention of the water in the belly due to the fact that the blood cannot flow through the liver well because of the shrunken liver. So the water portion of blood is leaking out into the abdomen, belly, form of the water. And varices, which is basically the ectatic, the dilated small vein in the esophagus or stomach, as a result, the blood is shunting away from the liver because it's hard and shrunken. So that those small blood vessels in the esophagus and stomach get dilated. And potentially, these things can be problematic because it can rupture and bleed. So doctor needs to know about this and treat it if needed to prevent someone to developing from the bleeding. And last one is hepatic insanity. Basically, that is a phenomenon where the liver cannot detoxify the ammonia, which ammonia is one of the toxins that can come from the food through the intestine, or from your breakdown of the muscle from the person. I mean, the ammonia usually get cleared through the liver, but someone with the end-stage liver disease, such as cirrhosis, this process is helped or interrupted, so that the ammonia is shunted over to the brain and make the brain sort of semi-comatose, like slow process. So next. So what is a liver transplantation? So it is a surgical procedure where someone's diseased liver is replaced with a whole or partial liver from someone else. It doesn't have to be blood share person, but the liver is taken out and replaced with someone's full liver or half of the liver. And it is established as only definitive treatment for cirrhosis. And there's mainly two types of liver transplantation we need to know about, which is deceased donor liver transplantation, meaning full liver is coming from someone who died and donate their livers. And also living donor liver transplantation, liver partial half of the liver is coming from someone who are alive and donating the half of the liver. And liver can grow back within 60 days or so for a person. So left side shows deceased donor liver transplantation. So the liver is taken out with a blood vessel, cut, and then replaced with a new liver, and blood vessels are sewed together. And in case of the living donor liver transplantation, half of the liver from a healthy donor is implanted in the patients. And again, the liver grows back usually within about 60 days or so. So this shows the liver transplant history. I mean, in 1963, first liver transplantation performed by a doctor named Thomas Stargill, who is now at the University of Pittsburgh Medical Center. And then since then, earlier in 1960 to 70, people didn't do well after liver transplantation, mainly due to imperfect surgical technique and availability of having good anti-rejection medication. And over the years, with the advance in science, we're able to get the better and better drugs, anti-rejection drugs. So now the 1-year survival after liver transplantation is like over 90%. But in old age, like 60, 70, it was dismal, like 20, 30%. So in terms of the other data, the 1989, first living donor liver transplantation was done in Japanese group. And then 94, the better anti-rejection drug, many of you might be taking this, but it's tacrolimus was introduced. And 98, the CellCept mycophenolate was introduced. 2003, sirolimus. 2013, lace when everolimus drugs was introduced, FDA approved in the United States. So what is the process getting evaluated for liver transplantation? And who are the team members? So team members consist of a transplant surgeon, transplant hepatologist, social worker, coordinators, psychiatrists, and cardiologists. And then it is similar to any surgical process, pre-evaluation process, where the surgeon's job and medical doctor's job to make sure that the patient who is undergoing certain procedure will be okay, will be able to sustain the process, surgical process. So that entails getting labs, getting CAT scan or MRI to make sure that there's no cancer or any other reason that can preclude the person from liver transplantation candidacy. And getting a heart study such as echocardiogram, cardiac stress test to make sure the heart is strong enough to endure the liver transplantation surgery. And possible lung function test if a person has any long-standing history of lung disease or smoking history. And for females, it is required to get a mammogram and pap smear to rule out any cancer or any type of cancer screening, such as cervical cancer or breast cancer. So liver transplant, the organ allocation is based on the scoring system called MEL score. So model for end-stage liver disease. So, and when patient get introduced to the transplant center, the patient's name and conditions are entered in National Registry for UNOS, United Network for Organ Sharing. And then that person's priority, on the waiting list, is determined by scoring system called MEL score, which is a complex mathematical model that utilizing 3 factors, which is creatinine, which is a kidney function, bilirubin, which is a liver's ability to detoxify biliverdin or bilirubin, and INR, which is the liver's ability to produce the coagulation or clotting factors. And that this scale goes from 6 to 40. 6 meaning the person is much less ill. 40 is a person gravely ill. They're like in danger of their life. They need to have liver transplantation quickly. So as you can imagine, the higher the score, the person going to go on to higher on the waiting list. Or lower the score, the person going to lower on the list. And then it is also classified into blood matching, the ABO types. So there is one type they have to make sure that the person is matched to the organ. So for instance, the best scenario is getting identical blood types, so blood type A to A. So it has best survival after liver transplantation. And the other compatible blood type is blood type O, which is universal donor to any other blood type A, B, or AB. Is acceptable. Incompatible blood type, which we do not want to use the A or B to O blood types, so which is incompatible. So there's typically these patients typically do not do well after liver transplantation. So why is MEL score important? Well, scientifically it's rigorously studied that the MEL score closely predict the survival or a risk of dying from liver disease without liver transplantation within the next couple of months. For instance, so when MEL score is less than 9%, these are the patients who are hospitalized in any university hospital. less than 9, the person's chance of dying from liver disease within the next 3 months will be less than 4%. Whereas when MELD score is between 20 and 29, their chance of dying from their liver disease within next 3 months is 76%. That's very high. When it's 40, is 100%. The patient 40, they are bedbound. They need to be in the hospital setting constantly. I mean, and typically these patients are going to top of the list like in a 1 or 2 list. So this is the allocation region in the United States dictated by UNOS. New York State is region 9, that's 11 region 9. So typically New York and California has the longest transplant waiting time as a result of organ shortage. So it is very important to be like an organ donor and share the promote promote the awareness of this organ shortage and then being active donors. So this is from 2010 data from UNOS. In year 2010, there were approximately close to 16,000 patients listed for liver transplantation. And how many liver transplantation did you do? Like maybe a little less than 2,200. So remaining patients were still waiting for liver transplantation. This is all due to organ shortage. So survival is getting better and better. Again, the science is advancing, and then we are getting better and better anti-rejection medication. At 1 year, the patient survived 90%. Actually, should be a little bit higher than 90%. This is from the 2003 data, 84%, but nowadays about 90% or so. I mean, and as time goes by, it decreases a little bit as a result of mostly due to the patient's non-compliance to medication or the reoccurrence of the liver disease, like hepatitis C or the autoimmune hepatitis, etc. Liver cancer for liver transplantation. In old days, like 1980 or so, I mean, they stopped doing liver transplantation for someone with liver cancer because the outcomes were quite poor. However, this doctor from Spain and Italy, Dr. Majorfaro, when he published this paper in New England Journal of Medicine, he demonstrated that if you do liver transplantation carefully for patients with a certain size and characteristic of the liver cancer, you have equal outcome and very high chance for cure. These characteristics are the one person has a single tumor less than 5 centimeters, or the up to 3 cancer, but none of the cancers greater than 3 centimeters. And there's no evidence of a cancer spread into the blood vessel outside the liver. If you do liver transplantation, they're cured. Their chance for cure is about 85% chance, and equal to survival. So they have equal survival as opposed to someone without liver cancer. So this has been basis for doing liver transplantation for someone with liver cancer here in the United States. Briefly, new update in UNOS is that they have a new mandate, new law in the UNOS called Share 35, meaning because of organ shortage, some other part of the United States region have more organ than New York or California. So they had to amend this to make sure that the patients who are sick, with high MELD score, have better chance to get a liver organ, perhaps from other regions. So it's called Share 35. So they started in June 2013. So UNOS let liver to be shared for both local and regional patients on the wait list with MELD score of greater than or equal to 35. So this should help. So now let's talk about the life after liver transplantation. So these are common medication you may encounter after liver transplantation. These are anti-rejection medications such as tacrolimus, cyclosporin, mycophenolase, Celsep, sirolimus, everolimus, and the prednisone. These medicines are vital for sustaining the health of the new liver. However, have some side effects. You need to know about these side effects. These side effects include high blood pressure, hypertension, kidney problems, elevated sugar, and about 25 to 20% of patients may go to develop diabetes after liver transplantation, unless they exercise, watch their diet, and follow doctor's instruction. Tremor, headaches, sometimes they may develop a tremor or headache, nausea, diarrhea, hair growth. Is common with cyclosporin. All of a sudden you see hair growing from your head and elsewhere, so it can be seen. Obesity, weight gain, high cholesterol, hyperlipidemia, and osteoporosis. So people should be encouraged to take vitamin D, calcium, and exercise on regular basis. Certain diet or drugs should be avoided in the post-transplant setting, such as fruit like grapefruit should be avoided because it can elevate or raise the program or cyclosporin level to toxic level, very dangerous. So we often tell the patient to avoid the grapefruit. And then if you're a primary care doctor or someone is prescribing new medication, you should consult your hepatologist or transplant surgeon to make sure they're safe to use. But there are a lot of drugs that can interact or interfere with the metabolism of the drug, the anti-rejection drugs such as Prograf or others. So compliance after liver transplantation is a key to success, to healthier and the better life. So and the patient should continue to follow with their primary care physician and transplant hepatologist and surgeon periodically to make sure that if there's any sign, early sign of the problem, that they can intervene quickly so that it doesn't go on to develop a bigger problem. So, and then study clearly shows that the compliance reduces the risk of developing graft failure or the so-called rejection, cellular rejection. So lifestyle, the well-balanced, I say usually low sodium because a lot of these patients will develop high blood pressure. So having low sodium diet is still beneficial and possible. Exercise regularly, and the most important, be happy, be positive. If you're happier, then you have less chance of developing infection. Dental care. Let's talk about dental care. Everyone goes to see their dentist yearly. I mean, so do you need to give them antibiotic? Well, the study has shown that we don't have to give them antibiotic, but quite honestly, a lot of transplant centers still like to give antibiotic, but they do not want to take a chance. But when you're looking at the scientific data, there's no strong evidence suggesting that after liver transplantation, we have to give them antibiotic. A lot of transplant centers in the United States, they may say, yeah, why don't you take some prophylactic antibiotic right before your dental care. Tobacco, smoking. I think everyone should stop smoking, but there's, especially post-liver transplant setting, after liver transplantation, there's a higher, remember I said that after liver transplantation, there's a greater instance of having diabetes, obesity, hyperlipidemia, right? And kidney issue. These are risk factors for heart disease, silent heart disease. So the patient should be encouraged to stop smoking. And then also the tobacco is directly linked to increased risk of a certain form of cancer after liver transplantation, such as esophageal or head and neck cancer. So that should be another reason why everyone should stop smoking. Also, right after liver transplantation, there's some data show that smoking can lead into vascular problems, blood vessel problem around the liver. It can create a clot called the hepatic artery thrombosis. So the most transplant centers like the patient to stop smoking even before liver transplantation. How about the marijuana? Great, right? So a lot of people asking about marijuana. Is it safe to use before or after liver transplantation? We're not 100% sure, but there's some data in non-transplant patients showing that if you have a liver disease, underlying liver disease, it can accelerate the progression of the liver disease. It can cause liver fibrosis. Yeah, but in healthy young people without liver disease probably doesn't cause any liver harm, but someone with liver disease, you should be cautious. And then also even post-transplant setting, there's some concern that maybe this can be contaminated with some fungal spore if you don't take care of it carefully. I mean, so that theoretically there's increased risk of having fungal infections. So, so just keep that in mind. How about cancer? So after liver transplantation, people are at slightly higher risk of developing cancer. Cancer. These cancers are usually head, neck, or esophageal cancer. If you have any history of prior history of heavy drinking, heavy smoking. So you need to see your doctor on a regular basis for screening, whether you need to have endoscopy done, check your neck, lymph node checked out. And also skin cancer is common, so every year your primary care physician should check your skin for any evidence of skin growth. If so, they can just take a biopsy or take it out. And also you should routinely check your skin on mirrors, when you take a shower, etc. You can check your skin to make sure there's no new growth or etc. I mean, how about breast, prostate, lung, colon cancer? There's no strong evidence showing that these people are at increased risk of developing these cancer. However, there's one exception. If you have any history of bowel disease or the form of liver disease such as primary sclerosing cholangitis, or having history of IBD like ulcerative colitis or Crohn's colitis, these people are at higher risk of developing colon cancer after liver transplantation. So they typically require colonoscopy once a year. Otherwise, the remaining cancer screening is based on your primary care physician, based on the available guideline. How about sexual function? So cirrhosis is bad for fertility. Really, the 50% of the female who are cirrhotic at reproductive age, they do not have a period. And then also cause a sexual dysfunction in terms of affecting your libido and erectile dysfunction. But issue is that right after transplantation, you have brand new life. I mean, and then your sexual function come back quickly. So it's very important. You gotta use contraception after liver transplantation. And you don't want to be surprised. And surprised like right after, right? Yeah. So you should use contraception. And when can you be pregnant? So some person might ask me, when can I try to be pregnant? Well, wait at least 1 year. So after 1 year, you can consult with your liver physician, a transplant hepatologist or a transplant surgeon. Consult with them and then plan for there's a lot of drugs we use in transplantations are category C, meaning potentially harmful to fetus. So it's very important to plan this event, plan out advance. So you gotta talk to the physician. So they may have to play around or change your drug regimen around that time. So this is a National Transplantation Pregnancy Registry data. So it's not that bad. I mean, in general population, the risk of having the congenital anomalies in fetus is about 3%. In post-transplant patient, about 4 to 5%, very slightly higher. But one thing you have to think about is rejection, because the pregnancy itself can lead into potentially the rejecting your new liver. Your body can reject your new liver. There's a risk is about 10%. So that during the pregnancy, your doctor has to monitor your drug level, such as tacrolimus and a program level very close to make sure that you don't get into the rejection problems. So anyway, congratulations on your new birthday. This is my information. If you have any questions, you can call me or email me. My practice is about 10 minutes away from here. But I'll be available at end of the event to answer or speak to anyone, whoever.
Well, if anybody has any questions.